So the good news is in the frontline setting, what we are doing right now is typically using 4-drug combinations. It's in combination with a monoclonal antibody and with, you know, the proteasome inhibitor, the immunomodulatory drug, and dexamethasone. So in essence, what we're doing is using all our classes of drugs up front. So at the time of first relapse, they're pretty much refractory to all of these treatments, which I think is a big challenge. And that's part of the reason why we had this session in the morning where we talked about moving some of the T-cell directed treatments earlier on. Now, the second challenge, which we've sort of alluded to, is, well, we are in a space where we have lots of T-cell directed therapies, so that's good news. But the problem there is, how do you pick and choose? Obviously, each of them has their benefits and their negatives. CAR T-cells, you have to wait, and that's why we saw the early manufacturing, off-the-shelf approaches. With the bispecifics, albeit the responses are a little bit lower, they're off the shelf and ready to use right away. Now, what is the best sequence? Should you use a CAR T-cell first? Should you use a bispecific after? I don't think we have enough data. The numbers we were talking about this morning are small, and I think we as a collective society need to do more studies on sequencing, whether you do a CAR followed by a bispecific followed by a CAR. Those are studies we need to continue to do, and with those studies we need to start understanding T-cell function, T-cell responses, biomarkers of resistance and response, and we still haven't gotten that. If you ask me my personal preference, I would much rather prefer doing a CAR T-cell approach if I can, followed by a bispecific, so that you're not exhausting the T-cells by the time you get to the CAR.